Hey everyone, welcome to this explainer. I am super excited to guide you through a fascinating and honestly incredibly important clinical topic, benign breast disease. We're going to be looking really closely at its pathogenesis, the clinical features, and modern management principles. I'm proudly presenting this explainer as a project developed by Palak Goyal under the expert guidance of Dr. Bhavani Rauser, and just so you know, it is strictly aligned with the latest NMC medical guidelines. We've got a lot of dense, high-yield pathophysiology to cover today, so let's jump right in.
Here is a quick roadmap of our clinical framework for today. We'll be covering understanding the ANDI concept, evaluating pain and nodularity, common benign breast lumps, acute breast infections, and finally, chronic and specific infections.
All right, let's start with Section 1, understanding the ANDI concept.
To truly wrap our heads around benign breast disease, we actually need to ditch old, confusing terms like fibrocystic disease. Seriously, toss it out. Instead, we're embracing a much more modern physiological framework called AND, which stands for aberrations of normal development and involution. The key takeaway here is that most of the benign disorders we see in the clinic aren't actually independent diseases at all. They're really just simple variations or aberrations of normal, cyclical hormone-related changes in the natural life cycle of breast development.
Think of the breast as a totally dynamic structure. Its pathology perfectly maps to its biological age across a patient's entire lifespan. So from 15 to 25 years, the breast is undergoing lobular development. Aberrations here give us conditions like fibroadenomas. Then, from 25 to 40 years, normal cyclical hormonal changes take over, and aberrations can cause exaggerated pain and nodularity. Finally, from 35 to 55 years, the breast tissue undergoes involution, and as things shrink down, kinking of the ducts can actually lead to cyst formation. It's a surprisingly beautiful, logical progression when you look at it this way.
Moving right along to Section 2, evaluating pain and nodularity. So, armed with that developmental timeline, evaluating symptoms gets a whole lot clearer. The absolute most common manifestations that bring highly anxious patients into the clinic are diffuse breast pain and nodularity. We call this cyclical pronounced mastalgia. It's breast pain that follows the menstrual cycle, usually showing up around day 14 and ramping up in severity until day 28, often with this generalized lumpiness. And, this isn't some random occurrence. It's literally just an exaggerated response of the breast tissue, specifically the stroma and epithelium, to completely normal circulating estrogen and progesterone.
Okay, so what does this mean for management? The crucial point is figuring out how to manage this effectively, without overtreating the patient. We use what's called a step-up clinical protocol. The very first and honestly the most important medical intervention is just to rule out cancer and reassure the patient. You pair that reassurance with practical advice, like wearing a well-fitted sports brassiere. If the pain is still hanging around, we step up to evening primrose oil, which contains gammalinic acid. Only when those simple steps fail do we ever consider bringing out the heavier anti-estrogen medications like tamoxifen or danazol to directly counter that hormonal response.
Now for Section 3, common benign breast lumps.
Let's shift from generalized diffuse pain to a scenario that demands a highly methodical diagnostic approach, finding a discrete, benign breast lump. It is absolutely fascinating how perfectly these lumps map right back to that ANDI timeline we talked about. Let's compare the two most high-yield benign lumps. The fibroadenoma is an aberration of lobular development, so boom, it naturally appears in that 15 to 25-year age group. The breast cyst, on the other hand, is a product of lobular involution, so we see it way later, generally in the 35 to 55-year bracket. Even the way they feel clinically is totally distinct. One is firm, the other is fluctuant.
Let's zoom in on the fibroadenoma for a second. Because this encapsulated tumor is so incredibly smooth and literally slips right away from your palpating fingers during a clinical exam, it's earned a pretty famous classic nickname. Clinically, it is widely referred to as the mouse in the breast.
On the flip side, breast cysts present as fluid-filled cavities. They often pop up suddenly, which, as you can imagine, causes a ton of alarm for the patient. A smooth, simple cyst seen on an ultrasound, that generally just needs observation. But if the ultrasound shows a complex cyst, meaning there's a solid component hiding within that cyst wall, that completely changes the game. A core biopsy is absolutely mandated right then and there to rule out an underlying malignancy. No exceptions.
On to Section 4, acute breast infections.
All right, we are shifting our clinical framework entirely right now. We're leaving hormonal aberrations in the rearview mirror and diving into true bacterial pathologies. But before we get into the nitty-gritty of acute breast infections, I want to pose a quick question to you. How do bacteria actually breach the defenses of the breast tissue in the first place? Think about the anatomical barriers for a second.
and what might compromise them, especially during lactation. Well, in lactational or puerperal mastitis, those normal bodily defenses are compromised by trauma from breastfeeding. Bacteria, usually our old friend Staphylococcus aureus, find a way in through cracked or retracted nipples. If the lactiferous ducts get blocked up by epithelial debris or just poor latching, you get milk stasis. The bacteria then cause that standing milk to clot, they multiply like crazy within that clot, and eventually they form a painful abscess.
Once that abscess forms, how we handle it is critical, and it represents a massive paradigm shift in modern surgical principles. Back in the day, surgeons relied heavily on open incision and drainage, but nowadays, we actively avoid that in lactating breasts. Why? Because it carries a ridiculously high risk of creating a chronic, non-healing milk fistula, not to mention a pretty poor cosmetic scar. The modern standard of care is much smarter. Ultrasound-guided aspiration of the pus, backed up by appropriate anti-staphylococcal antibiotics, and of course, continuous emptying of the breast.
And finally, Section 5, Chronic and Specific Infections.
Let's wrap up by looking at some non-lactational, highly specific chronic infections. These are pretty rare, but they are absolutely critical to recognize because they can easily mimic malignancies during a clinical exam. First up is periductal mastitis. Just like the name implies, this is a chronic inflammation located specifically around the major subareolar milk ducts. The big takeaway here? Its incredibly strong association with smoking. It presents with subareolar abscesses or fistulas, and while antibiotics are your first line of defense, definitive surgical treatment often means we actually have to excise the major mammary ducts.
And this next visual brilliantly illustrates our other specific infection. Take a close look at this clinical presentation of tubercular mastitis. You can clearly see the multiple, chronic, pus-discharging sinuses. Notice that classic bluish discoloration of the surrounding skin and the really distinctly undermined edges of the tubercular ulcers. This visually striking presentation is often bundled with matted axillary lymph nodes, which is exactly why it can so easily be mistaken for inflammatory breast cancer. Because it looks so much like cancer, nailing the diagnosis is paramount. Management relies entirely on getting a specific bacteriological diagnosis using tools like GeneXpert and a tissue biopsy. And here is the absolutely crucial point. Mastectomy is not the treatment for breast tuberculosis. Instead, management requires a long, dedicated course of anti-tuberculous chemotherapy, combined with just simple aspiration or drainage of any cold abscesses.
Okay, we've covered a ton of complex pathology, intricate imaging, and surgical principles today. But remember, beneath all of that dense clinical data is a highly anxious human being sitting in your clinic waiting for answers. I want you to always keep this quote in mind. Remind the patient that 90% of breast lumps are not cancer. An accurate diagnosis isn't just about knowing the biology. It's about having the absolute confidence to provide the ultimate, most effective treatment in benign breast disease, which is genuine patient reassurance. Which kind of makes you wonder, how many other areas of medicine could benefit from simply reassuring the patient first?